I just want to say welcome everybody, 2026. I don't know how it got to be 2026 already. Anyway, it's great welcoming you to the first of the Methods Mondays of 2026. And I know Jordan led the way for the fall, and there was lots of really interesting talks as well. Nora's kicking us off on measurement, and I feel like from a measurement perspective, it's like ground zero when we think about health systems and services. I just came from a meeting over in the UK, and they spent an hour and a half talking about like how to decide on measuring their impact. And so, I mean, and that was a pragmatic real world question they were trying to sort out. So, I mean, it permeates the to determine the value of what we do and what people are thinking. Nora is an associate professor, Dr. Fayed, at the School of Rehabilitation Therapy. For anyone who doesn't know her, her life's work is around measurement, all things measurement. And she's such an expert. I've learned so much when we co-taught the methods course together. She has a specific interest in quality of life outcomes explicitly. And so if you ever want to get her talking excitedly about anything, just throw the word quality of life and she will start talking for a long time. But she's generously offering to do a series of talks on measurement. And I personally would love to hear her talk about measurement. This is a general one, but she's happy to do a series of measurement talks anywhere from like what measure should we choose, making sense of measurement. So Nora, I'm so grateful that you're spending an hour with us sharing your knowledge, but I think it would be wonderful to ask everybody, as you go along, what topics, because in my mind, I'm going to say yes to everything that you offer. So I'll hand the floor over to you and say thank you in advance. I have to slip out to teach, but thank you.
First of all, can everyone hear me well? Great. So thanks for having me. This is really the first time I've put together these thoughts in this way. So the way I'm thinking of this talk is a meta talk about methodology. And so I'm not going to be talking about the details of how to do outcome measurement in itself. And that would typically happen I think in a Methods Monday where you're going to get some more like meaty methods talk, but this is more meta around our methods. Um, and meta research pertaining to interventions or intervention studies as a whole are pretty common. But I would say that when we're thinking about outcomes, this is more going to be about the choices scientists make of what to measure and what the implications of that are. So I am offering upcoming Methods Mondays talks, more detailed on methodology of like content analysis, for example, and more detailed thoughts on selection. Okay, my buttons aren't working. So now I'm going to mouse things. There we go. What is an outcomes researcher? I identify as an outcomes researcher, but what is it? I think an outcome, at least in health sciences, is kind of a measurable aim of a construct that's worthy of study. So I'm particularly focused on constructs with your ideas or people's ideas about things that aren't directly observable. So Catherine mentioned quality of life. I think I'm going to just focus on person kind of perceived health for the purpose of this talk, because I think that's more of a unifying construct among us. I think many of us at HSPRI care about what people think about their own health. And it's not a directly observable thing. So it's not easy to point at a person and say, on a scale of 1 to 5, this is how healthy they are. And so I specialized in the non-directly observable, but I understand that the way we think about clinical tests or what they call in the medical literature of objective tests might be perceived a little bit differently. But I still think everything's up for grabs when we're talking for outcomes research, as to, essentially we're talking about what are we going to measure? Is this worth studying? And if it's worth studying, do we want to change it? Do we want to change it as a result of a treatment, an intervention, or a policy? So when you're interested in studying constructs, it's important to get it right because ultimately you need to know what exactly it is you are going to be impacting. So again, that thing for me has been quality of life and patient perceived health. So why do outcomes research in the first place? I alluded to this before, but initially I was drawn to outcomes work because I had to choose a measure in my PhD to do the intervention work that I really wanted to do. And the measure wasn't available. And I kind of had to figure that out in a very systematic way. And that turned into an entire career for me. So I just like this quote from Isaac Newton, which is, you've got to measure what's there, what's measurable, and make measurable what is not. So making measurable what is not has been my life's work. And thinking about making measurable what is not is what I'm going to talk to you about today. So, as I said, I started out in outcomes research and I never left it. But I can tell you what I am not, what is an outcomes researcher is not. An outcomes researcher is not a researcher who's seeking to develop better treatments or therapies or new interventions. And in some ways, this is kind of lonely relative to many of my clinical contemporaries with clinical backgrounds, because we often get started in research because we have a new way of doing things, we have a new treatment, we have a new approach. It kind of deviates from things. And just like to kind of provide some context of when I got started and the environment that we often typically work in. So when I was doing my PhD, there were kind of two main research frameworks that were presented to me as options. So the first on the left here, at least it's on my left, was evidence-based research frameworks, where the evidence for decision making or the way we constructed knowledge was around a hierarchy of methodology, moving from the bottom at expert opinion and observational research, all the way up to experimental research in the form of the clinical trial, and ultimately kind of meta-syntheses or reviews of those trials. And once you had those, then you had good reason to kind of take it and import it into practice. And if that quote unquote evidence was not being used in daily practice to promote a proven effective treatment for patients, then an implementation science framework, so this one on the right, was what you needed to do in terms of research. You needed to do that in order to bridge the gap between this very high quality evidence and knowledge at the top and what people are actually doing. So those were the options that seemed available to me in the scholarly environment where I was developing at McMaster, which makes sense because that was kind of a hub for both of those kind of ways of thinking, and very kind of dominant in health research methodology within Canada. And I don't challenge this hierarchy of methodology if the goal is to construct evidence about whether a treatment might work for a group of people in a population with a certain health problem. But I was always kind of concerned that a lot of this evidence was not constructed within the pyramid based on a foundation that I identified with. It wasn't obvious to me that we were pursuing the right goals. So in particular, I would hear a lot of statements around the effectiveness of particular treatments or interventions without the additional caveat and definition as effective for what, according to what criteria. And with much digging and determination, I often found that the criteria for effectiveness might not be about the ones people needed to know about in order to make decisions about their health. So, for example, one of my home conditions when I kind of got started, and I still care about this group very much, were children with epilepsy. And one of the biggest healthcare decisions children and families with epilepsy struggled with was whether to pursue epilepsy surgery or not. And by the way, that's kind of it's a difficult thing to decide on because you effectively will be removing a portion of a child's brain while they're in the process of developing. So the surgery was touted as effective on the grounds that it was very safe and likely to reduce seizure activity. And that's true. But those outcomes of safety and seizures were rarely emphasized as caveats on the idea of effectiveness. So if your surgeon was saying it's going to be the research shows it's effective, what do they mean and what do patients hear? So there was an assumption that reduced seizure activity would translate into the ability to learn and grow unhindered by epilepsy, as if it never happened. And that's kind of the research shows what families are pursuing. That was their target when they were thinking about good outcome. But that's not actually necessarily true at all. In fact, we don't know if epilepsy surgery does that till this day because there were no or very few surgical trials available to demonstrate the effects of surgery on things like learning, memory, school, peer acceptance, or even in, later adolescence, independent community mobility. And those were priorities for people. And that is a problem that highlights the crux of my talk today, which is, are we measuring the right things from the first place? So I've clumsily abbreviated it as ART from at this point, and I'll be working on the acronym, but for the purpose of this talk, we're going to call this question of, are we measuring the right things in the first place as ART? Okay, ART. And I'll try and bring us back to that as we go. So I'll take us through some examples that are going to be more specific to me and my area of research that I know, but I think it's important for everyone here to try and see if they can make those connections to their areas to see if it applies, because you'll be doing that much better than I could. How are we doing for time? Okay. Oh, look, there's a little ruler there. Okay, so I understand words like right. Are we measuring the right things are really wrought, especially in a scholarly discussion. Bear with me. One thing that's easier to do than identifying whether someone is doing art is noticing when it didn't happen in the first place. And this is because you can't answer important questions without the measures that allow you to do so. So what is okay, instead of saying it's right, is to declare and contextualize my assumptions about what right is. In this case, I'm going to adopt an assumption that health is defined according to the WHO definition of health in something called the International Classification of Functioning and Disability in Health. I have no sense of the extent to which my audience is familiar with this framework. And I can't see all of you at once. I'm going to try. I can't do it. At any rate, I'm just going to try and review it. Catherine, do you think you have a sense of the extent to which the audience is familiar with the ICF?
I'm looking at who's here, and I'm going to say a good chunk are, but a good chunk might
Or
not be.
not? Okay, so let's just assume that, just like the WHO said in the original charter, that health is not just the absence of disease, right? So you can't just count whether you have a disease or not to assume that somebody's healthy. You have to have complete psychosocial well-being. This kind of maps that out a little bit better. So if a person has a health condition or a health label or category, it could affect the way their body works, how well they think, how their cardiovascular system is doing, how well they can move, for example, those are, or even how their emotions are controlled. And that also can affect what you can do with your body, which are your activities, the tasks that you do from day to day, and your participation in society, which is essentially thought of as like your roles, the things that I for example, have to participate in society as, as an assistant professor. That's my job. And I'm also a mom. And those are kind of the roles that I have. So when all of those things are functioning in harmony, I have functioning. And functioning in this framework is essentially health. You can't be healthy if you can't function. The cool thing about this framework, and we won't talk about it much today, is that it can go in the other direction, right? When you have breakdowns in the roles that you need to do or want to do, it can kind of affect your body too. And so that is, that's essentially all of these things need to be in harmony for you to function. The opposite is when things like these break down, when your body is not in harmony with your ability to do things or the roles in your life, then you're encountering disability at that point. So disability isn't just a categorical label, right? You have a spinal cord injury, you have a disability. It doesn't quite work that way. It's this idea that, when you have a spinal cord injury, if you can do all the things you want to do and need to do with the body that you have available, then you have functioning, and that's positive. And you're moving towards a state of health, even though you're not moving around in the way that other people without a spinal cord injury don't. And then keeping in mind there's these other things called contextual factors like environmental factors. So those include the people around you in your immediate environment that support you or kind of hinder your health, like families, for example, or larger health systems that you work in. And personal factors I won't talk about too much, but it means kind of the things that make you uniquely you, like how resilient you are, or even things about yourself that you can't change, like your culture or your gender. Okay, so the thing about this framework is it also seems kind of nebulous. So in pure WHO classification style, WHO style, it comes with a classification system. So in case there was any confusion about what constitutes an activity or a participation, what constitutes a body function, it's all mapped out with these like thousands of alphanumeric codes. And depending on the level of granularity you're looking for in the content, you can map out some of these non-medical health states. And it's a companion to the ICD-10, which maps out, the diagnostic codes and so these can interact very well. So just to make sure everyone has got it right and we're talking about the same things, there are ways of classifying lab tests and clinical assessments and self-reports and survey-based measures with the ICF and the ICD-10, okay? And that's what I worked on in my PhD and even beyond. And just the methodology for doing this to make it really easy to compare the actual individual items of measures or these clinical tests across studies. So we know if art is taking place from like within a clinical category or across languages in this kind of universal way. And this method was updated in 2019. We finally got around to publishing it. It only took 10 years. It's fine. And it has since been cited 700 times. So it has been useful to other outcomes researchers. So I'd like to share a problem I faced as a researcher interested in child health and drawing from Canadian population health data to position my work. So for example, in order to write that first paragraph of a grant or an article, I would need to know how well Canadian children have been doing. How is their health? How is their functioning? According to like relative to other developed countries. And the way we know that is usually through OECD data, and that stretches back even further than 50 years. So I wanted to get a sense of the progress we made. So here's my question. How well have Canadian children been doing relative to other developed countries over the last 50 years? The only outcome variable that even allowed me to ask such a question or answer such a question was infant mortality. That's the only one. So if we go back all the way, let's say I wanted to go back to the 1980s, the only one that was uniform, the only outcome available was infant mortality. So I was able to, on the one hand, I got to see that we were doing very well in the 1980s relative to the other OECD countries on the indicator, the outcome measure of infant mortality. And I also got to see that we dropped quite a bit in recent times relative to the other countries. By the way, it's gone down overall. We're just lagging behind other groups that we compare ourselves to. So I only have that indicator of how well Canadian children were doing, but it was very specific to survival. It's very specific to the beginning of childhood, and I would say it's pretty insufficient for answering my question. So by the way the data is structured that we had from 1980s until now, and we've fallen relative to in our relative ranking, but we also can't answer the question because the outcome isn't there. A better outcome indicator of how Canadian children were doing was this idea that's more consistent relative to the ICF. And this is a common disability functioning question in multiple surveys across the world, population health surveys, which is, how are you doing in your daily activities? Are they limited because of a long-term condition or health-related problem? So that's more consistent with the ICF definition of health. And this question is pretty standard. So as I showed, so that's what I wanted to say about that became present and started to show up in disability surveys in Canada post the ICF, so post 2001. I think it took some years to to show up. However, it wasn't available until 2016 for people below the age of 15. So I still cannot answer the question, how are Canadian kids doing relative to other countries before 2016? That's the only comparison. And I'm not going to necessarily get into the data, but I can tell you we were kind of like in the second tier, and now we're in the third tier in the 2020s. So again, we're falling behind even on this other indicator. My point here is that regardless of your discipline, if your work is about people and there's no evidence for the important questions without the presence of art, the art has to be there for you to find the evidence that matters. So, how do you ask your questions about health if the art measures aren't there in the first place, those important measures? If you're thinking about populations as opposed to clinical samples, you have basically little to no influence, depending on where you're positioned, about what outcomes are available in population health or statistical data that's gathered on a population level. So here is an example of the best option I would have available to answer that. So my strategy was to borrow from larger jurisdictions like the US or Europe, and they did so in this study here. So this study was about a minimal generic set of domains of functioning and health. And what they used is first they looked at this question, this very general question. It's highly common. We call it the SF1. Overall, how would you rate your health? In fact, it's so common, sometimes they even ask you at the doctor's office, right? And it's in most population health surveys, and that's self-perceived health. And they drew from different kind of data sets, which so the national, a United States survey, a German survey, and multiple clinical surveys that ask questions and related the predictors to that overall, how would you rate your health, right? So they could take all the other questions asked, specific questions asked about people's health, like walking, going to work, sleeping, whatever it is. They could ask them, look at those specific questions in those surveys and see what explained the variance in those short form surveys. And to do that, they had to do that mapping, right? Like they had to do that mapping relative to the ICF, that classification system. And a lot of sophisticated methods like statistical techniques in like different ways they looked at random forest and group lasso regression. The data, the clinical data spanned 44 countries. So they're combining both population health and clinical health data. And this is what explained the variance. These are the outcomes. It was these predictors of health, energy and drive, emotions and pain. These are kind of these green ones of the body functions. And then over here is carrying out your daily routine, walking, moving around, and employment. So again, this is a culling of many, probably hundreds of different potential predictors of perceived health into the ones that explain the most variance in that question, the ones that explain the most ups and downs in what you would see when people are rating this question. So I'd like to point out the results because now I can begin to share what is art, at least for adults on this general level. So here we can see that a high proportion of what people define as art in an empirical sense comes from their body, and a lot of it comes from what they can actually do with their body. So people aren't on this population level, they're not talking about very detailed things about diagnosis. They're talking about, can I carry out my routine? If not, I'm not healthy. Can I move around? If not, I'm not healthy. Can I go to work? If not, I'm not healthy. And of course, not everybody in the adult population works, but when we were looking at this, when they were looking at this quite at large, that's what it meant. So I think it's safe to kind of assume that it also translates into non-remunerative employment for those adults as well. So I think that's kind of what I wanted to carry forward before we start talking about clinical. Let me check in on the time. I can't see my time on my, Catherine, what time are we at?
You are at 12:25. You're doing
25, great. Okay. At this rate, we'll probably have some time for discussion. So Is everyone with me so far? It's a good time to, okay, check in. All right, I'm seeing some nods of the heads I can see. Okay, so let's talk about what's important to measure in clinical trials research. Because people can say, oh, that's fine for population health, but clinical health outcome priorities are way different. So let's put a pin in that concern. It's a valid concern. It will be difficult to talk about art in all clinical research. So I'd like to hone in for the remainder of my talk on clinical trials specifically. And this is why. In 2024, there were market reports from various industries that the value of clinical trials globally was positioned in that year at $84 billion. $84 billion, with an estimated 6% growth anticipated over the next 20 years. So clinical trials aren't shrinking, they are expanding vastly. And although this figure includes public spending, as well as private spending on clinical trials, policymakers have been really aware, actually, of this problem of the growing impact of trials on society. In particular, what healthcare, what new treatments get approved and funded. Keep in mind, new treatments cost more than old treatments, right? So if those new treatments are targeting an outcome that is not meaningful or likely to push forward the health of your clinical group, but it's new. So a company is, once it gets into the market and once it's insured, a company's making a lot of money on it. The question and the other piece is not just the company's making money on it, is who's paying for it. The largest health insurer in almost any jurisdiction in a developed country is the taxpayer, right? So we are spending money on new treatments. And the question is, are these new treatments targeting the areas of health that are going to make more than a slightly incremental difference? And I would say this question is particularly important for people with chronic diseases, where we have figured out in a lot of these areas how to reach really, from a medical perspective, reach good outcome to a certain level. And what's needed after that is things around management, structural changes, supports, addressing some of the more vulnerable people within those chronic disease populations. And we can talk about examples at the end if you like. So the pressure point where policymakers have influence is with respect to things like, so it's expensive. They have influence in the area of regulation. So regulators can ask whether the right targets or in other words, outcome are being pursued. The other reason I like to focus on trials relates to, again, that gold standard of decision-making, which is shared decision-making, right? When you and your physician are trying to make a decision about a new treatment, you would like to know what the evidence is, but the evidence had to have the outcome that you're interested in order for that decision to be informed. So if those aren't being included, like for example, even in the long-term follow-up of surgical trials, in my example, it's difficult to talk about that evidence in an informed way. So that's why I'm just going to hone in on clinical trials research for today. So let's say a trialist or a researcher or even a treatment developer wants to ask or measure a target, and that's art, like something that is important to measure from the first place. How do they decide? Here, I would say there's actually a whole body of research called outcomes research devoted to this. And in particular, research developing something I call core outcome sets. So core outcome sets are a form of knowledge synthesis in and of themselves about outcomes, usually positioned around a certain clinical group or a certain clinical setting like ICU or primary care. Or for a population like children or adults or seniors. They can be really broad or really specific. And I did a recent cursory scan of core sets and found that there were over 250 available in the peer-reviewed literature. So it's not like they're not available. So this study, I'd like to point out, it was led by a team of my friend and colleague, Nina Kolamainen, and she synthesized core set outcome sets for children. They found 36 of them 441 of those outcomes were classified relative to the ICF using that method that I showed you, but didn't describe in detail, which is okay. We can learn it later. And you can see from the results, again, we've got this trend of the importance of activity and participation to health. Okay, this is repeatedly coming through. Like, it is the biggest category of what people perceive. And this isn't just patients talking now. Embedded in core sets are expert opinions and literature, right? So activities and participations outcomes are really important to the core of defining what makes people healthy in a certain clinical area. And this kind of spanned everything from pediatric asthma to gastrointestinal diseases and autoimmune diseases and so forth. So I think the unique thing about the clinical is that we've got this area here that we didn't have in population health, which totally makes sense, which is the diagnosis piece, the disease piece, and the mortality piece. So those outcomes are still important, especially for non-chronic diseases or high-stakes chronic diseases. So these studies are available, but are they being reflected in the places we need them the most, like in trials, which we use to make decisions? So in 2011, we asked this question, and we just kind of looked at those different components of the ICF, the outcomes that were reflected in the trials, both as primary outcomes and secondary outcomes. And you can see that 19%, so these numbers in the middle here, these blue and green ones, that's the carryover of the proportion of outcomes from the previous slide. Right, so over here, activities and participation outcomes were important 33% of the time. And so in what's actually happened the year we looked at things was that activity and participation outcomes were reflected in the primary outcomes of clinical trials 2% of the time, if I'm being generous, and 5% of the time for secondary outcomes, right? So like that's a really huge discrepancy. Again, we saw a really huge discrepancy for those environment kind of outcomes. So over here, 7.5. So those are things like social support, for example, or stigma or access even, which is important. And again, those things, there was a really big, there was a really big discrepancy here. Okay, so I'm highlighting these red ones because that's where the biggest discrepancies lie. Like I don't know if the difference between 19% and 36% is meaningful, but I do know that the difference between 2% and 33% is probably not just some error issue. Okay, so it's low. Less than 2% of trials look at activity and participation. So the basis for evaluating effectiveness is not being reflected in the research that's happening. So the good news is that the policymakers were and continue to be aware of this discrepancy between the treatments that are available and the outcomes people need. And policymakers, especially regulators on the regulatory side, can't develop new treatments. That's not their job. But what they can do is kind of say, well, you know what? We want patients who know about their own health to define things better. They have a better sense of what is important for them to move their health forward. So during the middle of my PhD in 2007, 2008, there was a lot of excitement around something called the FDA guidance for industry labeling claims for the use of patient-reported outcome measures because of this regulatory attempt to acknowledge, number one, the importance of what patients were feeling was important to them. And through that kind of like get at what are the important questions or the important outcomes, but also to make sure new drug approvals were not baking in outcomes that kind of favored them from the first place. So a good outcome as reported by a patient needed to be defined by the patient group in order for you to use it in a new labeling claim for a new drug. So that was good, right? And right here, the purpose of this slide that I have up here is that this was one of the few studies or two studies of a group where they kind of quantified what that did to the new drug approvals that were sought by the FDA, like the patient-reported outcomes. So again, Before the policy, they had a lot more of these patient-reported outcomes included in the trial, and that actually decreased. And it's because the quality of the measures had to increase before coming to the FDA, like the actual thing that patients were reporting on. It wasn't up to the drug developer anymore to develop a checklist of what they thought successful was based on this treatment, based on what it was already doing. You had to do qualitative work to actually ask the patients, what is this construct to you? What's a good version of this? So for example, if the construct was pain, how does pain look to you? And then they would have to measure pain according to what the qualitative said. So I think that's pretty kind of amazing, actually, and forward thinking that they were basing regulation on qualitative work. Okay, so the bad news is that the majority of these patient-reported outcomes were still overwhelmingly focused on symptoms. And so the policy on patient-reported outcomes had some meat in terms of getting them to make those outcomes better, but did it change what outcomes were being measured in the first place? Hence, what treatments were being developed in the first place? Many would say this is where patient engagement comes in. So patient engagement was and is an important component to addressing the problem of whether the most influential and important outcomes are being studied or targeted in the first place. So patients have a big role in defining what is art. However, my observations of patient engagement research is that it's not enough to do without an explicit discussion of patients defining the outcomes that are important to target in the first place. Right? So, for example, there's a lot of evidence to demonstrate that patient engagement has improved people's experiences of trials. Let's go back to trials. The trials are better. They have a better time going through them. They can get to them. The transportation is nicer. The materials are better. There's more representation from the clinical patients, maybe even some more diversity in the groups. But there's not going to be is that actually changing what interventions are being attempted in the first place, what questions are being asked, and what the targets of treatments are? So I would argue that though the benefits of patient engagement thus far have kind of been steered towards what the investigators need, and what the investigators need are to run better trials. And that increases the internal validity and the rigor of the trial. But I still don't know if it gets at the problem of demonstrating effectiveness according to how patients define effectiveness, or how people define effectiveness for themselves, in the way that if they were involved in the selection of that outcome from the first place, that could achieve it. Okay, so at this time, I've been in the process of updating that 2011 cross-sectional study and really getting more precise about not just looking at the content, but also who's reporting and who is selecting the outcome. So a lot of that granularity is coming forward in this updated review. And we're doing it for over a 10-year longitudinal study of clinical trials in childhood. And we're using the expertise of computer scientists like Farhana Zulkarnain in order to kind of automate this, because as I mentioned, like manually reviewing clinical trials is no longer an option. It's just such an explosion. So I can tell you on the kind of, we've randomly selected about 10% of the trials that were published so that we could manually look at this. And we found that over a 10-year period of about 1,000 trials, about 4% of them reported patient engagement. So, I mean, that's better than nothing. And I can say it happens more in the recent years than it happened in the years before. Maybe patient engagement was taking place, but only 4% are reporting them. However, of these, less than 1% are involving the patients in actually selecting the outcomes, right? So it makes me see there's this discrepancy between the rate of reported engagement versus engagement in outcome choices to target specifically. And so that even if engagement is taking place, the outcomes they're still not being driven. I think they're being driven by the treatments. I don't think they're being driven by the targets that patients are defining before the treatments are developed. So what are the solutions and recommendations? I do think that there are additional things regulators can still do, but I also think they've been putting more work into this than other sectors, including, sorry to say it, education and training, where I think it should be happening the most. It's sort of implicit in our practices and graduate training to ask our trainees to defend their questions. I think we can do more to ask them about why certain outcomes should be pursued over others before they think about the interventions. Also, so that's, our trainees. Health funders have been quick to support patient engagement strategies, and even we've gotten better at defining what meaningful patient engagement is, but I rarely hear concrete guidelines of how and when to involve patients in the selection of outcomes or why that's important. Like, I really don't see it in most patient engagement guidelines. And so I also think that we can start funding research where the trials that test interventions using outcomes that were selected from core outcome sets that were kind of like empirically defined as art with the support of the patient experts on the team. I think that should be something that we really think of funding a little bit more in order to put our weight as public scientists behind the interventions and the treatments and the therapies that are really going to benefit individual groups of patients, and in doing so, benefit society. I don't think we need to expect every trialist to reinvent the wheel and develop their own outcome prioritization before doing a trial. The starting point should be looking at those core sets and working with your group in order to select them as a starting point. So there's a lot of information out there. There's on what is the priority for your group. The biggest barrier is just getting other researchers and policymakers to pay attention and work backwards from the outcome. And that's not what we're used to doing. Not forward from the intervention that they think they want to do. Okay. So if I had to leave with one thought or one question, it would be, have we considered the art before we do the science? And that's all. Oops, sorry. Let me go back to that other slide. Thank you. Okay.
Thank you so much, Nora.
Sure.
Catherine and I would facilitate some questions since she had to jump off to head to class there about 10 minutes ago or a little less than that. So would love to open it up for questions, but I wonder if, even though Catherine's not here, starting with her question that she popped in the chat a little while ago, which is about the new quality of life indicators from StatsCan and whether you have any thoughts on those.
Okay, so quality of life indicators from StatsCan. I don't know what the new quality of life indicators from StatsCan are. I just know I'm not sure if you're talking about the ones that the Waterloo group is doing. So is there anybody who can kind of tell me which one she means?
So
Because I think I know what they could be, but I just want to make sure we're on the right page.
She put a link in if you're able to open it, but I think it was February of last year they released a new quality of life framework for StatsCan, and I think that I don't know this for sure, but I think the three new that they define as central indicators of quality of life might have been new. Some of the deeper layers were already in, like community health survey and things like that, but I think that might be what she's referring to.
So again, I would say in my experience, one of my challenges with Statistics Canada is that a lot of the innovations in our population health data in Canada in particular have moved forward on the adult side, but not the child side. And it's a strange omission for me. Having said that, I think that I have a sense of what went into these indicators, and they're quite broad, and we don't know what the usefulness of any one indicator is going to be over the other. And health and quality of life are not the same thing. So health is kind of a resource that you can use to potentially improve your life. And a quality of life it's really this interesting construct where it's contextual in that there are thresholds of common things that everybody has to have in order to have a good quality of life. And once you've surpassed them, and that's why in kind of like our international approaches to quality of life, we're counting like these basic needs, like housing, and we're counting things like, food access and security. Like people just need those things in order to have a good quality of life. But in developed countries, once we already have them, there's a threshold past which more of it doesn't really help us. And so the question, how any one of these components, the way they're measured, are going to predict how good our lives are, is going to, it remains to be seen. It's going to be dependent on our context. So they're all kind of right in general, but how right are they? How predictive, how powerful are they going to be for us? We don't know. And that's why we have to put them all there right now. But they're starting with a theoretical framework, which is a good thing because you won't be able to move forward if you don't have one, right? And that's kind of one of the ways that I think it helps me to ask the question in the first place. You don't have the time to ask every individual question for every individual context, but if you're using a theoretical kind of concept of what's important, what outcomes are important in the first place, then you can start generalizing information from study to study and seeing. So right now, it's clear to me that activities and participation is a really big gap in terms of perceived health for people with chronic diseases. Which one of these areas, prosperity, health, society, environment, and good governance, are going to make the difference to Canadian quality of life over time is remains to be seen. But a lot of quality of life as defined, like people thinking what they think about their own lives, that's kind of really difficult to change. It's kind of often baked in from an early age. It can change, but it's not easy to change it.
Thanks, Nora. Any other questions for Nora or comments? If
anyone wants to reach out to me outside of this context or challenge some of these ideas around, outcomes or outcome, Chad's got one.
We're not picking up your mic, Chad. I think you might be on your headphones.
Sorry about that.
Yeah.
You can hear me now?
Yeah.
Okay. Thanks for that, Nora. That was a great presentation. I learned a lot. I'd love to hear your thoughts on, there's are we measuring or the art side of things, but also how do you deal with situations where we do have the outcome, but we just don't know if it's captured the same way across, say, provinces. So, we're starting to look at, a lot of research, of course, is starting to become much more national level across provinces. I mean, we have international data. We saw it during COVID-19 that we're looking at mortality and maybe different countries measure it a little bit differently. And so I'd just love to, actually, and even with administrative data, we have ICS in Ontario. But in Manitoba, we have like the Manitoba Center for Health Policy, which captures data in that province. So I'd just love to know your approach on how you might sort of try to validate something that appears to be the same outcome, but might be captured differently.
So I guess what I would say is to come at it with the idea that you can't validate something that's not valid, right? First, you have to ask the question, is it valid to merge these outcomes? So I wish I had better news for you, but I think that's the best that you can do. And is it valid to merge these outcomes has kind of a content basis, right? Where you're saying, is this question comparable to this question? And there's a lot of dimensions to be able to mention. Some of that could be like mapping to the ICF, but there's so many aspects beyond mapping to the ICF that, if we discuss that methodology, the way you ask the question is so different, right? So like one of the examples that comes to mind is the PEDS QL, which is, kind of like the SF36 for kids. Ask, are you able to move and run as you like? And then there's another question from another scale. Oh no, they say it's difficult for me to move and run. And then there's another question that also assesses running that says, in a very common scale for kids, that says, can you run as you like? So both of those questions are asking about running. They'll both be mapped to the ICF as running, but one is asking about it from like the positioning of your expectations of running, right? Like if a kid has no expectations to run, they've been using a wheelchair their whole lives, then they're like, sure, as I like, fine. I do it the way I want to do it. And so I rate it very highly, even though I can't use my legs. Whereas, there's another child who's struggling with obesity or, some recent health problem, and their ability to run previously to the way they used to is difficult, right? And so you can't compare those two things. So there's a lot of work involved before you even start thinking about psychometrics, about merging and mapping outcomes. It's really, really hard. And yeah, I wish I had a better response for you, or like a more positive one. It's hard to work backwards from things that already exist and change them to suit each other. That's the short answer.
No, I think that's a great answer too. I think yeah, so I take it from your answer though, in those instances, you probably just wouldn't use that outcome measure to compare across
The best
countries or
you could
cities.
do is you could do some type of like quantitative like calibrating of one to the other, but it's always going to be
Right.
contextual.
Yeah.
It's always going to be specific to one, from one population to another one, and maybe the like the adjustment that you make from one measure to another in order to compare a population, it's valid at one point in time, but who's to say that you can still use that adjustment 10 years from now? So it's a lot of
Got it.
work to maybe not get what you need out of it.
Right.
There's a lot of chicken and egg problems when you're working with outcome measures backwards.
Right.
And that's why I think we need to like stop, put a pause in it, always be like, what is the target? Why are we doing this? What does this group need to achieve in order to move forward as subgroups within, a clinical condition of vulnerable people, or move forward on the whole? So like I like to think of diabetes, for example. Diabetes is, in that's one area where the outcome drives the interventions, and where we can still see gaps, even though we have all this ability to control blood sugar. Like diabetes was never a chronic condition, but because insulin arrived, it became a chronic condition. And there are better treatments. Like we've got the somebody help me here with the glucose semaglutides, the Ozempics. We've got the new Ozempics, and those are great, and probably much more effective in a different way along a different mechanism than insulin. But still, you're gonna have all these people who have problems with access, and that doesn't. They're more vulnerable. They can't, and they still need lifestyle support. They need good food security. They need to be able to pay for their medications and so on. And so those interventions are available. They're potentially much cheaper, and they can move the population forward. But they're not developing or prioritizing solutions around those at the same rate.
Awesome. Thank you.
We've probably got time for one more question. If anybody else has a question or wants to jump into the discussion.
Jordan, can you hear me? Or Dr. Fayed, can you hear me?
Yes, we
Yeah,
can.
I can hear you, Mir.
Okay, awesome. Yeah, sorry, I'm in the conference room with a lot of other people, so I was wondering if the microphone is working. But Dr. Fayed, again, thank you so much for this really important presentation. I took your class on research methodologies, and we have had these conversations before. I loved how you highlighted the importance of patient engagement in terms of which outcomes trialists should prefer. My one question is, like, we often see in trials that like patients they are given like a huge list of surveys, and sometimes they suffer from a bit of fatigability in terms of having to answer so many questions. Some at times those questions are even some like similar, but they come from completely different
Different surveys. Yeah. Yeah.
So my question is,
So you're talking about respondent burden in trials if we start doing this more.
yeah, exactly. So what you were talking about, that we need to engage patients more. Do you see with more engagement this respondent burden going down in the near future?
No,
Or
I see respondent burden going down when we get more strategic about the outcomes that we're targeting from the first place. So that involves patients to help us decide before you even get started on what the treatment is.
yeah.
So and so the issue of respondent, like I myself was, the lead outcomes person in a trial where we were looking at coordinated care and we didn't know what coordinated care was going to do. We were working forward from like, this is the best intervention that we have available. It's going to go away anyway. The policymaker is funding it. And so we use the patients to help define a framework. And then we threw it, they had to answer a lot of questions. But it's because we didn't know. We didn't know from the first place what the intervention was going to do. We were hoping that it could change all these things that the patients valued. But I'm saying in an ideal world, or in a world where we are designing things more thoughtfully, we would have been asking that question. We would have looked at that framework first and then said, what is the intervention that's going to change this? And then, how do we design it, and who needs to do it, and how would we get it done? And so, and who's going to pay for it, and all of those, what type of expertise do we need? Does it exist? I think in a lot of cases, we don't even have the clinical knowledge to get some of these things done, and our systems aren't positioned to do them. I can say with new medical treatments, that it's not the way they're developed. They're not developed with like, hey, what's the aim? What do we need to, people need to walk better. Can we make a device that helps that? Sometimes it happens, but I'm not sure it happens as much as it should. I think what happens instead is we've got this way of saying, okay, this is a disease, this is the mechanism disease, this is what we're going to target in order to change the disease, this is going to be the medication we're going to provide. And then there's, then we're not even talking about like non-inferiority trials where we're just looking for cheaper solutions or faster solutions for things that already exist. So I just think that it's growing so fast that if public scientists don't start talking about this more explicitly, it's going to be hard to present a different way of doing things. The benefit of people.
I think we're approaching the top of the hour. I think this is an opening of a great conversation, and I know Catherine planted the seed around maybe having more future measurement talks and going deeper in particular areas. So thank you so much for sharing your expertise and time with us, Nora. Our next Methods Monday is going to be on economic analysis on February 9th. Should be a calendar invite coming out soon with a bit of a flyer. Please feel free to feed in to Sherry or Catherine any ideas that you have of things that you'd like to hear more about. We'd like these Methods Mondays to continue to meet the needs like today around topics that are brought up by our HSPRI community around things people want to learn a little bit more about. So thanks, everybody. Look forward to seeing you all soon. Have a great day.